All right. Hello. Welcome everyone tonight. Thanks for signing on and checking out this doc talk. My name is Will Albiero. I am an orthopedic surgeon at OSMS. I practice primarily here in the Fox Valley in Neenah, as well as Wapaka. I am a sports medicine surgeon by training, but I do general orthopedics, which really entails everything in the upper and lower extremities. A quick bit about myself. I grew up in Southeast Wisconsin in Germantown. I did my undergraduate and medical school training at the University of Wisconsin-Madison. And then I did my 5-year orthopedic formal residency training in Akron, Ohio at the Cleveland Clinic Akron General Hospital. And then I did one additional year of training up in Minneapolis at a program called TRIA, focusing on sports medicine treatment. I enjoy doing all types of orthopedic procedures. In the sports medicine world, that involves a lot of minimally invasive or arthroscopic surgery, particularly of the shoulder and knee. But general orthopedic surgery entails a little bit of everything, community trauma, and all sorts of general orthopedic problems. But tonight we're going to talk a little bit more about knee pain in particular, different knee conditions and different treatment options. And this is certainly designed to be an event in which questions are encouraged. I think that's more fun for everybody, including myself. So if you have any questions along the way here, please type them in the chat area. We'll answer every question that we can, hopefully get to everything that comes up. So a little bit about knee pain. I don't want to talk too much about this. I want to get to some questions, but I think it's important to understand what the knee is all about. It's a very complex joint. There's a lot of things that can affect the knee and cause pain, cause functional issues, and cause life problems. And I think some basic anatomy is important. There are 3 primary bones that make up the knee. That is the thigh bone or the femur, the shin bone or the tibia, and then the patella, which is the kneecap. Those obviously have to be functional and effective for the knee joint to be a working joint. But then there's so much more to it. There is articular cartilage that makes up the ends of those bones. That's the shiny white tissue. I often tell people at the end of a chicken bone, you see that shiny layer of tissue or cartilage. That is articular cartilage. And the wearing away of that cartilage is by definition arthritis. So it's important to know what that is. There are meniscus pads in the knee, 2 specifically, one on each side, and those are pads that they protect the joint and they prevent arthritis in the future. So meniscus injuries are very common. We'll talk a little bit more about that as well. And then there are a few important ligaments that stabilize the knee, the ones that most people have heard of, the ACL, the PCL, then the MCL, and the LCL. There are a lot more ligaments to the knee that help with stabilization as well, but those are the 4 crux or primary ligaments. And then a lot of soft tissues. Including all the muscles that span the knee, the quad muscle, the hamstring muscles, even the calf muscles coming from below, and a lot of soft tissue structures. It's important for all of these to be working effectively, dynamically, to make the knee functional and to prevent it from hurting and giving you problems in life. A few very common knee problems. We'll get to these in the questions too, so hopefully this spurs on some questions moving forward. But knee arthritis, very common condition. That's the wearing away of that cartilage at the end of the bone. And along with that often comes injury or damage to the meniscus pads between the bones as well. There are a lot of treatment options for arthritis. Those always start conservatively. There's things we can do to help temper arthritis. Unfortunately, arthritis it's a progressive problem. It continues to march forward. The body does not know how to grow new cartilage. We do not know effectively how to reliably grow new cartilage and put it back into the knee, at least with degenerative wear and tear of the knee. So it's important to try and minimize the progression of arthritis. There are things we can do along the way to help it, but in the end, the definitive treatment for an end-stage arthritic knee is a total knee replacement. Meniscus injuries are very common. Those pads of the knee can be torn acutely, like with the specific injury. They can also wear down over time. We call those degenerative meniscus tears, and those are probably more common. Just because you have a meniscus tear does not mean that you have to have surgery by any means. A lot of people are walking around in this world with an unhealthy meniscus and the knee is doing very fine. But sometimes those tears can cause symptoms and problems, and they can be addressed with a variety of treatments. Sometimes repair, and then sometimes actually just cleaning up the meniscus if we're talking surgical options. You can have acute injuries to the important ligaments of the knee. The ACL and MCL, I think, are the two that are most commonly talked about, probably most commonly injured as well. So you might hear about that in professional athletes or really in friends and family. It's that common of an injury. In terms of how we treat those, again, we'll go more through that with some of the questions in the down the line here. But ACL injuries are often treated with surgery. The ACL is a pretty important ligament for knee stabilization. It prevents that shin bone from moving forward underneath the femur. And it also provides rotational stability to the knee. So that's why people often injure that ligament with a cutting or twisting type activity. And without it, you lose that stability and that support. So most people who are active, who are healthy, who have goals of remaining healthy and active, we talk about ACL reconstruction surgery. The ACL is not very well repaired, so we don't fix the ACL. It's a procedure where we actually use a graft, whether from your own body or from a cadaver source, to put a new ACL into the knee. And there's a lot of different ways to do that. If you guys have questions about that, we can certainly talk more about it. Fortunately, most MCL injuries on the inside of the knee, that is a ligament that tends to be very self-healing. So for most MCL injuries, conservative treatment is the ticket. At the same time, in high-grade injuries, sometimes MCL reconstruction or repair is necessary. And then oftentimes with high-energy injuries, you can have multi-ligament knee problems where multiple ligaments are injured, causing some pretty significant issues with knee stability and knee function, and that leads to more complex treatment and often complex recovery and rehabilitation, and then sometimes poor outcomes than in a single ligament injury. Other injuries that we see, patella, the kneecap is a unique bone in the body. It's under a high degree of force and strain. Anything that we do, that we bend the knee and put weight through the knee, stairs, steps, squatting, running, it's under a lot of force. So a lot of things can happen to that, whether it's wear and tear of the cartilage under the kneecap. That kneecap can be unstable, where it slides back and forth, leading to either subluxations or dislocations. Sometimes the patella can be responsible for just general pain in the knee. Even if the x-rays and all the workup is negative, there's a condition called anterior knee pain or patellofemoral syndrome, in which there's pain around that kneecap area that is not quite able to be targeted as to where it's coming from. And there are certain treatments for that too. We can talk more about that deeper in the talk here. And also overuse injuries, just like everything else in the body. Especially in this day and age when everyone's trying to be active and push, the knee is subject to those overuse injuries as well. I think it's important to think about the knee. There's all these soft tissues and muscles and ligaments that keep the knee intact. And sometimes our mind might get ahead of our body with regards to how hard we want to train and push. And just like any simple machine in the world, it can only handle so much. And when you push it beyond that, the knee will let you know, and it'll tell you one way or another. And a lot of those ways that it tells you is by when you have these overuse injuries, whether that's patella tendonitis, also called jumper's knee, IT band syndrome. People can get IT band syndrome. It's a large band of tissue that runs from the hip down to the knee, but it can affect down the lower aspect and outer aspect of the knee, particularly in runners and active folks. So there's a lot of different things that can affect the knee joint and overuse patterns, as well as acute knee injuries, chronic knee injuries. Pretty complex organ. So let's take some questions. We'll move on here. We have some questions that were pre-submitted. I'll go through those first, and then we'll obviously collect more questions on the side. So what is OSMS doing to help keep patients safe during the pandemic? And that's a good question. It's been about a year now, so what we've been doing has changed over the course of the year, and I think fortunately we're getting to a more stable point now with vaccinations and with everything else. So there's a lot of things we're doing when people enter the door. There's initial screening measures, temperature checks, and this is for everyone, for patients, guests, even for our team members as well. There is a mask policy in place, so everyone is to wear a mask when they're in the building, patients, team members, and physicians. We recently went from a no visitor policy to a single visitor policy. And the goal of that is to just limit the number of people that are coming through the clinic, which is a helpful thing to avoid congestion. Additional disinfecting, sanitizing, cleaning measures in all patient rooms, seating areas. We encourage social distancing. That is, everyone's let know that as they enter the door. We do that. We have different measures throughout the building. And then we do encourage telemedicine visits still. That was very big early on in the pandemic, but it's still a very viable way to talk to and treat established patients for checkups, and we're still utilizing that pretty effectively. So it's certainly on our mind and something we're constantly addressing and readdressing as different CDC recommendations change and are updated. So on that note, is it safe to have surgery during the pandemic? And I do believe that it is safe at this time. It's a very good question. For a long time, we were really, for months, putting a hold on all elective surgery and just proceeding with urgent and emergent cases. That has changed now. We are proceeding with elective surgery, but there are a lot of parameters in place to help make sure we're minimizing the risk of disrupting the health of our staff, of our patients, of all the healthcare workers, minimizing the risk of transmission of the disease. And those are a lot of the things that we talked about earlier, whether it's screening patients at the door, surgeries for patients that would even have COVID. So first off, everyone's getting tested for COVID 2 to 3 days before their surgery, and they're screened. And even in emergent cases, if someone has COVID, those cases are happening in different operating rooms and with very specific restrictions and precautions. So I think we're hyper aware at this point. And generally it is safe, I think, to have surgery. At the same time, if you're a high-risk person and there's in hyper concern, it might not be a bad idea. If you have a condition that requires an elective procedure that can be put off, that's perfectly okay to do that. But we have a lot of things in place right now that is making surgery as safe as possible for everybody. All right. Let's see, when is it time to see an orthopedic surgeon for knee pain? That's a really good question. I think the answer to that, first off, I think there's a fear factor when people come in to see a surgeon. And that's just something I've noticed in my early practice. People come and when they talk to a surgeon, they expect that there is going to be a surgical recommendation. That's just not the case. I talk to patients all the time about their knee arthritis, whether it's the first time it's being diagnosed or some other condition, and the go-to is conservative treatment off the bat, and that ends up being the only treatment many times. So I would try to calm that anxiety a little bit, that when you go to see an orthopedic surgeon, not all of us surgeons are quick to pull the trigger if we don't have to. But I think when you have a joint problem or a limb problem that is not responding to typical treatment measures, when you've given that, say it's the knee, when you've given that knee time to rest, when you've stopped the aggravating activity for a period of time, when you've iced, elevated, used some anti-inflammatory medications, a lot of the simple things that maybe you've done in the past that have worked for you and they're not working and they're affecting your quality of life, that might be the time to say, all right, let's get this checked out. I think that's important too, because we see plenty of patients who push through a condition or problem longer than they should, and then once they finally make it into the clinic and the problem is diagnosed, the window for treatment of that problem may be gone, because a lot of injuries, you'd like to get after them sooner rather than later for a variety of reasons. So having a problem diagnosed sooner rather than later can be really helpful with making appropriate management decisions. But I think the overall gist is when what you're doing isn't working and the pain or the limitations are persistent, that's probably a good time to be seen. How can I tell if my knee pain is caused by osteoarthritis? That's a good question too. I think one of the simplest deciders is a patient's age. We know that young people tend not to get arthritis in their knee. They certainly can for a variety of reasons, but the majority of people that have that development of arthritis are middle-aged to older. But I think the tried and true way to know is this arthritis causing the knee pain is an X-ray. A radiograph of the knee can very definitively tell us what the cartilage looks like at the end of those bones, whether it's wearing down and to what degree. And there are other signs that the knee will show us that it's been under duress for a period of time. So an X-ray is a very definitive way to say, yes, this is arthritis, or this might be something else. How do I know if I may have torn or partially torn my ACL? And then what is the difference between a partial and fully torn ACL? Also a good question. So like we talked about, that ACL is a very important ligament in the knee for stability. And while I think it's more commonly fully torn when you completely disrupt the ACL, it certainly can be partially torn. The ACL is made up of, it's like a rope made up of multiple fibers. And there are actually certain bands of the ACL that perform different functions. It's a more complex ligament than many give it credit for. Sometimes you can injure just one of those bands, and sometimes you can completely disrupt the entire ACL. So that's the difference between a torn and a partially torn ACL. And the treatment options differ on that as well, too. While you could have a partially torn ACL, oftentimes the necessity of surgery is not it's not there with a partially torn ACL. If there's enough fibers to keep your knee stable, and that's the key, if you have a stable knee that allows you to remain active, cut, pivot, and twist, and the knee's not collapsing or giving out on you, and on a physical examination by a healthcare provider like myself, if I examine the knee, there are specific tests we do to check your ACL, and if your ACL feels taut and intact, we can compare it to your other side. Even with a partially torn ACL, that can work very well for you. So that's kind of the difference between a fully torn and partially torn ACL and how treatments differ as well. How can I keep my knees healthy and pain-free? This is working okay, sorry. Very good question. A question that everyone should have on their mind is, how can I prevent further injury or prevent knee problems? The number one answer to that is to remain active and maintain a healthy weight. We know that body weight very much correlates to knee pain. And every, a stat we often talk about is every pound lost takes 4 pounds of pressure off the knee. So it's really kind of an exponential increase in terms of the relief that the knee feels with weight loss. So those things in particular, if you're asking for a way to keep the knees that are healthy, and if you want to stay healthy and remain pain-free, those are the tickets to really keep the weight off and keep your core to floor muscles, your lower extremity, as strong and well conditioned as you can. What are some good low impact exercises for the knees? Good question. While running is great activity, great exercise, I certainly encourage running if people like it and are passionate about it. It's undoubtedly a high impact activity. So alternatives to that are biking, swimming, elliptical machines, rollerblading, ice skating. Anything that's avoiding repetitive high impact activity of the knee is good for not necessarily preventing arthritis, but maybe from, if you have an arthritic knee, preventing it from flaring up. Really the gist of that is cross training. Different activities work different muscle groups and use and load the knee in different ways. So by cross training, that just means doing different activities. If you're passionate about biking, that's all you love doing, that's okay, but it's important to mix in maybe a jog here and there, or swim, whatever it may be. Not only is it good for your knees, but it's probably actually good for your body and helps with injury prevention. Just looking at some more questions here. What are some non-surgical options to help my knee pain? Very good question. A lot of good non-surgical options. It depends on what the knee condition is as well. But there are certain things like activity modifications. So if something hurts your knee and you can avoid that activity or change the way you do it, that's perfect. That's a very non-invasive and fairly easy way to help your knee pain. Using medications like over-the-counter anti-inflammatories, Aleve, ibuprofen, or Tylenol, which is not an anti-inflammatory, but it can help with pain. Physical therapy, so whether that's formal therapy with a therapist, or if that's just home exercises or a home exercise program designed to strengthen your leg and the muscles around your knee, that can be very helpful. Bracing, there's different types of braces for different knee conditions, but bracing with activity can be a helpful adjunct. We talk about injections of the knee, and we can talk more about that a little bit later, but they can be very helpful for calming down inflammation in an irritable knee. So there are a lot of non-surgical options to consider depending on the condition. Are there any treatment options for a bone-on-bone knee other than knee replacement surgery? That's a good question. Typically not. When you have bone-on-bone arthritis, and it's the chronic type of bone-on-bone arthritis, like the degenerative wear and tear of a knee, there's not a lot of good options besides knee replacement, which essentially is resurfacing that knee, getting rid of the arthritic surfaces, and replacing it with plastic and metal parts. Like I said earlier, we don't know how to regrow cartilage in that fashion just yet and reliably implant it diffusely over an affected knee joint. People hear about cartilage procedures because we do cartilage procedures in certain situations, but those situations are pretty select, and oftentimes those are small focal cartilage defects, when there's a defect that's maybe 1 or 2, 3 centimeters in size and diameter, and they're isolated, and the rest of the knee, the cartilage is healthy and intact. But when you have diffuse wear and tear of a knee, and it's true bone-on-bone arthritis, there's not many good options other than a total knee replacement. Sometimes, depending on age, you can consider things like osteotomies, where you change the alignment of the leg, and you can do different. These are kind of extreme measures in salvage situations for people that are too young to ideally receive a total knee replacement. But as you get into the middle and older years, a knee replacement is just too reliable of an option. We know knee replacement surgery. It's tried and true. It's on hundreds of thousands of knee replacements per year for the last few decades, and only climbing. So the technology is there, the techniques are there, and we know it works. So while there's always other options being explored, and that's what the orthopedic science is diving into as we speak, and has been for some time, right now I don't think we have a much better option that I'm aware of. What is a root tear? That's a good question. A root tear, the root is describing a specific portion of the meniscus. So I have a diagram here. I'm not sure how well it's going to show up, but I think it's helpful when you're showing a root tear to describe that. So this is a knee right here, and you can see the femur portion. The blue portion of this knee is the articular cartilage that wears away with arthritis. And if I bend down here just to show you the tibia, these white semicircles that are C-shaped here, that's the meniscus. And the meniscus is attached to the bone by roots. So this is difficult for me. So there's a root in the back, and then a root down here in the front. And same thing on the other side, a root in the back and a root in the front. And those roots are what anchor the meniscus down to the bone. So we know that one particular type of meniscus injury is a root tear, where the actual anchor comes off the bone, or you have meniscus tear directly adjacent to where it anchors. And that's a tough problem, because when you lose that integrity of the meniscus there, essentially the entire meniscus on that side is not functional anymore. It loses its ability to kind of act as a trampoline and capture the weight of the femur, which is how it protects the cartilage. So you can imagine if you eliminate the where the root attaches to the bone, the meniscus is afunctional, and that's a problem. So in recent years, there's been enough evidence to show that we should get a little bit more aggressive with repairing root tears and not just cleaning out the meniscus at that part. We should do our best to attempt to fix. Now, there are definitely certain contraindications to that: degree of arthritis, alignment of the knee, body weight, a lot of things that we know and have been tried and true in the literature that if you try and repair the meniscus, it won't work. And what you don't want to do is a surgery that isn't going to be successful, is going to put a patient through unnecessary risk for minimal benefit. So we try and follow those parameters pretty closely, but we've become better at identifying root tears, and the technology has become improved and the techniques for how to fix them. So good question on the root tear. That's a good one. How much does a total knee replacement weigh? I don't know the answer to that question, but it's not very much. That's a great question. I'm going to look up the answer and I'll get back to you guys if I can. It's not much. In my estimation, it's equivalent to the bone that's removed. So I don't think a knee replacement adds any additional weight to your knee. Is it common to have hip pain after you've had knee pain? And what can you do to get rid of the hip pain? That's not uncommon at all, actually, because the hip and the knee and the ankle, they all work as a unit. And sometimes when one part of that wheel is disrupted, there can be compensatory issues and pain through the other components. So with a knee injury, it's not uncommon for someone to develop hip pain when they have knee pain. And same thing in the ankle. And it kind of goes vice versa. If you have bad hip arthritis per se or a bad hip injury, knee and ankle pain can ensue as well. So, how do you treat that is a good question. I think you nip the problem in the bud right away. So if you can find the source, if the knee is the problem, if it's arthritic or injured or damaged or unstable, that's the problem you treat. And then hopefully over time, as you recover from that, the associated injuries will bounce back and recover as well. But at the same time, if it's been something you've been dealing with for a long enough time, and you develop true pathology of the joint next to the knee or whatever it might be, that might be a whole separate treatment. Maybe hip arthritis developed from the knee arthritis because of the way that you were walking and utilizing that hip. That can certainly happen. So, a good question. Yes, they can certainly be associated. Sometimes they're treated as separate entities, but oftentimes when you treat the source and the primary problem, the rest of that wheel or the rest of that limb will respond appropriately and recover too. I hear about knee scopes. What are they and when would you need one? And I'm looking at some questions up above me as well as on my phone here. So this ties into another question. Do you do minimally invasive total? Oh, I shouldn't. I'm trying to mix too many questions together. I hear about knee scopes. What are they, and when would you need one? A knee scope is a minimally invasive knee surgery. So knee scope, that's short for arthroscopy. Arthro means joint. Scope means to look. So knee arthroscopy is a minimally invasive way to evaluate a knee. So to perform a diagnostic look at the knee, by using typically 2, sometimes 3 small poke holes around the knee, less than 1 centimeter in size. We put a device into that knee through one of those poke holes that has a camera. It has a light to light up the knee, and it also has fluid that enters the knee, and it pressurizes to a certain point. It's tough to look in a dry knee, so you need that knee to be filled with fluid, and this is for any joint that you do an arthroscopic procedure on, and essentially turns it into an aquarium type setting. And with the light and the camera, you can really evaluate all the important structures of the knee. You can look in the front, back, side, and get a very good evaluation for what's going on, what problems might be there, what you need to do. And then through your other incisions or other portals, you can use small tools that are designed to work in the knee through those small portals and do work, whether that's cleaning up a meniscus, cleaning up cartilage. That was the initial role for arthroscopic surgeries, was essentially a lot of scissors and shavers to cut out damaged structures. But now we're doing a lot of surgeries almost exclusively arthroscopically, like ACL surgery is done for the most part through small incisions. So it's a really good way to have your joint evaluated diagnostically, and then to have a procedure completed. And some of the benefits are less pain, lower risk of incisional concerns or infection. So there's certainly perks that come with it. That's what knee scopes are. Now, I think you should clear up too. A lot of people say, I just need a quick knee scope. Or my friend had a knee scope procedure. He was back to work in 1 week. So, some knee scopes are quick procedures. If it's the kind of surgery where you're cleaning up the knee, say cutting out some of the torn meniscus or cleaning up some ruffled cartilage, that's a cleanup procedure. That's a 20 to 30 minute knee arthroscopy procedure that typically is a fairly quick recovery. So that's a quick knee scope. But a more invasive knee scope, like an ACL reconstruction surgery, that can take a couple hours and obviously involves much more recovery, much more rehabilitation, and much more time. So knee scope can mean a lot of things, but typically it means a surgery done through small incisions and minimally invasive with a camera. Do you do minimally invasive total knee replacement? I do not. I do a standard total knee replacement with a standard anterior or front of the knee midline incision. I would not call it minimally invasive. I know there are certain techniques and people that claim to do minimally invasive surgery, but the gold standard by far is a standard incision over the front of the knee. It spans the kneecap. It goes down to the top of the shin bone and then up a little bit onto the femur. So that is my total knee replacement of choice. Can I get an overuse injury? You can get overuse injuries all over your body, and the knee is certainly subject to that as well, whether that's IT band syndrome, patella tendonitis, chronic hamstring injuries. You can certainly get overuse injuries. And the treatment for most overuse injuries is stopping or limiting the activity that's causing the pain. We know that the injury comes on because it's been overused. Unfortunately, that type of pain or pathology takes time to come on and develop. So unfortunately, the recovery also takes time. It's not typically a quick fix when you have an overuse injury. It takes patience. It's difficult to stop that activity that may have brought it on, like if you're passionate about running or biking, because oftentimes that activity will have to be modified or limited. So it takes patience, it takes time, often therapy, sometimes steroid injections or other types of injections can help alleviate that pain a little bit quicker. But yes, overuse injuries are probably one of the more common things that I see in my orthopedic clinic. All right, I've been having pain in my right knee for about 1.5 years. This is a good one. I continue to exercise, avoiding lunges and certain squats because they hurt. Sometimes I'm fine after exercise. Other times I have pain while going up or down the stairs after just running or walking on the treadmill. The pain feels like it runs vertically over my kneecap. Is this likely my patellar tendon? Resting for a few weeks at a time seems to help, but the pain keeps coming back. When I start exercising again, is there anything else I can try? My doctor had me taking a leave daily for about a month, but it didn't seem to change anything, so I stopped. So that's a good question. That's a patient who's having patella tendon or patellar type pain or anterior knee pain for a good amount of time. It sounds like it's tried a few things with activity modification as well as anti-inflammatory. That's a good place to start. The pain that's being described in that particular case, it sounds like it's patellofemoral related pain. That could be the patella tendon, that could be the patella itself. So there's certainly a lot of, the patella is a kind of a complex bone and a complex structure with how it works. So that might be a case where it's worthwhile to have an evaluation. When you've had pain for that long and the things you're trying and doing aren't helping, I think an x-ray can tell you a lot. It can give you an indicator if there is some arthritis or some wear and tear. It can also reassure you when you say the knee joint looks good. The cartilage, from what we can tell on an x-ray, looks healthy. that can help alter some treatment options as well. In that particular case, that sounds like somebody who might be really responsive to a combination of decreasing aggravating activities such as running and biking, and having a course of formal physical therapy to really have someone evaluate how the knee is working, where are your strengths, where are your weaknesses, and developing a specific treatment plan. As we know with knee pain, the quadricep muscle plays a very important role with alleviating knee pain, the stronger that it is, particularly certain parts of that quad muscle too. So sometimes it takes a little bit of an expert like a therapist to evaluate and identify that, and then really guide the exercises and treatments that might get you over the hump. So good question. What is the right time to undergo knee replacement surgery? Very good question. That is a decision that I will leave up to the patients for the most part. And the reason for that, there's a lot of things, as we talked about, that we can try for knee arthritis, a lot of things that we use to try and slow down the process or at least temper the pain that comes along with arthritis. But it's a progressive problem that typically tends to get worse. And once you've tried everything that you are comfortable trying or that you're able to try in terms of conservative treatment options, and you're still experiencing pain and or stiffness and or functional problems, and your quality of life is being affected in a negative way, and you're a good candidate for knee replacement based on x-rays and other health factors that your physician can help you work through as well, that's probably a good time to consider knee replacement surgery. But it's a definitive procedure. We cut out the ends of the joint and replace it with metal and plastic. So I do like to make sure patients feel ready for that they've tried everything they can. It's no longer working. And then that is the reasonable next step. So in general, the right time is when you feel ready, oftentimes when you say mercy. At the same time, I don't want to tell people to keep pushing through pain forever, and then they're at a point in their life where some of their quality or important years, whether that's playing with grandchildren or traveling, are beyond them. So there is a time and a place for knee replacement surgery. That's a good conversation to have with your surgeon and with your family and friends and people you trust about when is the right time. What is a partial knee replacement, and how is it different from a total knee replacement? So a total knee replacement is when we replace 3 compartments of the knee. I can use this diagram to show the first 2, or this model, excuse me. There's a compartment on the outside, on the inside, then the third compartment is underneath the kneecap. There's no patella on this model, but that's what we call tricompartmental osteoarthritis. The majority of patients with knee arthritis are candidates for total knee replacement, which is replacement of all 3 of those compartments, because most of the time all 3 of those compartments are involved to some degree. A partial knee replacement is when only one of those compartments is replaced in a single surgery. That's most commonly the medial or inner compartment. It can sometimes be the patellofemoral compartment, and more rarely the lateral compartment. But in a situation where you have isolated knee arthritis to a single compartment, typically the knee has to be stable. So that means your ACL and PCL have to be intact and healthy. And then, we don't want people to have conditions that might weaken the soft tissues of the knee, like rheumatoid arthritis or some other inflammatory conditions. So there are certainly some criteria that you have to hit to be a candidate for partial knee replacement. And as we use all those check boxes and benchmarks, it really does narrow down to a pretty small group of people who are candidates. So for the most part, we're doing total knee replacements, but a partial knee replacement is certainly a good option in the right person. And a partial knee replacement in the right candidate can lead to incredible results and very, very quick recovery. How many years does a knee replacement last? The number that we typically tell people is 20 years. A good knee replacement will get you 20 years. Now, I've seen patients who've been working on the same knee for 35 years, and then we know that some knee replacements wear out for other reasons over the course of a few years. There's a whole variety of reasons why that can be. I won't go into all those, but a good knee replacement that is doing its job and working well should last you a good 20 years. It's a very good question. I wish I had a more definitive number to tell you, but the reality is there's some play in that number in both sides. Do I recommend any natural supplements for knee pain or preventative measures? Very good question. By natural supplements, the one natural supplement that I think has gotten the most press recently that I've seen more patients taking, and I will often suggest it as something if they're looking, is turmeric. And prescription dosed turmeric can be a natural supplement that has been shown to help with arthritic type conditions of the knee and other joints. Other than that, I typically don't recommend anything very aggressively. I'm not sure there's been enough data or research to say definitively that one thing is more helpful than the other. A lot of these natural supplements are safe, so they typically don't cause more harm. But do they actually help or prevent knee arthritis? We don't know that. A couple supplements that are historically and even today still used commonly are chondroitin sulfate and glucosamine. We don't have enough evidence to show that those truly help with arthritic knee pain or prevent arthritic knee pain. So I don't recommend them in the sense that I don't tell people they should go and purchase it and use it. At the same time, it's extremely low risk. The biggest downside is that there's some cost associated with those medications. So if it's something that you've used or you've heard being used by friends and family and it's been effective, you can certainly try it. If it's helpful for you, great, and that's okay. But I wouldn't go out of my way to tell someone that they need to start this to help their knee arthritis. I've been avoiding needed knee surgery for a decade or more and would like to explore the appropriateness of the Calypso approach. Do you know it and do you do it? Thanks. My answer to this will be pretty brief. The Calypso procedure for the knee is a extremely new procedure being trialed right now for knee osteoarthritis. And I am no expert by any means. I know that it was being trialed at The Ohio State University. And I believe that trial phase is still in place. And what I would say is, no, I'm not doing this. I'm not sure I'm able to do this. It's only in the trial phases. So they select a very few, either surgeons or group. And that's under very strict precautions as to when it can be done, how it can be done, how the results are tracked. And from what I know, there's no long-term or even short-term data at this point to show its effectiveness. But it's an alternative to knee replacement surgery or to arthritis of the knee that is very much in the early phases. And I don't know enough to tell you when that'll be open and available to the general public, where you don't have to be in some kind of a trial to have it done. Good question. I saw the new surgery center is open. Why would I want to have my surgery there rather than at a hospital? Also a very good question. I think there are a lot of reasons to, if you have the option to have your surgery done at an ambulatory surgery center or a surgery center rather than in a hospital-based setting. So one of the primary reasons is efficiency. So when you have a surgery done at a freestanding surgery center and like ours, an orthopedic specialty center, it's much more efficient. There's only a certain number of procedures that are performed there, and thus because of that narrower scope, it allows for more specialized care, smaller, more personalized teams, more operational efficiencies that come with the volume of those specific cases. With that often comes less time spent at the surgery center as well. So that's before your surgery as well as after your surgery. Because of those efficiencies, things tend to move a little quicker. And I just say this from my experience working in both a hospital setting as well as a surgery center. Safety, there's typically less people, less hustle and bustle at a surgery center. So the risk of contagious disease is certainly reduced to some degree. Less stress. I know in the hospital setting, a lot of hustle and bustle, people, hallways, rooms, departments, parking, etc. I think if you can minimize some of the logistical issues, it's just helpful for the patient and the family. more predictable scheduling too. In a hospital setting, you have an emergency room right downstairs that could bring in an emergent case at any time. There's a lot of different surgeons and specialties all going at the same time, so there's definitely the risk of having a procedure delayed or sometimes and rarely canceled. I think in a surgery center, those uncertainties are less, and the timing of your procedure and your day it's a little bit more reliable. And then cost as well. Typically, cost at a surgery center is lower than in a hospital-based setting. Lower payment rates, which can certainly have benefits for patients, insurers, taxpayers as well, because of the efficiencies that come. Oftentimes, we can make sure that those procedures happen in an efficient way with only the necessary equipment. So that's a side benefit to having something done in the surgery center rather than in a larger hospital-based system. Good question. What about fish oil supplements? There's no data to suggest that fish oil is particularly helpful for joint pain or arthritic pain. Now, for cardiovascular health, I'll be honest, I'm not totally keen on and up to date on my literature as to where that stands. I would ask your primary care physician or cardiologist as to the role of fish oil in cardiovascular health. But in terms of joint pain, knee pain, arthritic pain, no good evidence to show that it's particularly helpful. What is the best treatment for IT band pain after a knee replacement from a year ago? So that depends on the timing of the IT joint pain. Is it a new type issue that's just come on a year after your total knee replacement, or has it been there for a year? If the problem has been really tagged to the IT band and it's not a problem with the total knee replacement or the components or related to the incision or the approach, the initial treatments for IT band syndrome are a very dedicated stretching program. There's certain stretches and exercises, as well as foam rollers and different techniques that can work out that pain. Anti-inflammatories, activity modification is certainly helpful. Strengthening the hip muscles, specifically the abductors and rotators of the hip, can be very helpful for that pain, even down in the knee. And then sometimes, if it gets to the point, we'll consider steroid injections right at the focal area of pain by that IT band. Sometimes that IT band can be rubbing against the outer aspect of the bone called IT band friction syndrome, and that can respond very nicely to an injection to help with the inflammation, and then continued stretching exercises to help lengthen that tendon or that band so that it's not so taut and rubbing as aggressively on the outer aspect of that bone. So, good question. What is your opinion of laser treatments and stem cell options that I see advertised? That's a very good question that I think we're all still trying to figure out the answers to. And I say it's a good question because I think we're all just kind of flooded with that information, whether it's through billboards or magazine advertisements, whatever it may be. The reality is, I don't think we have, if you're following the data and the literature, and the studies that look at this stuff, it's hard to say that these are reliable treatments for knee pain. A question we get asked a lot are stem cell injections, and there's been no good data to suggest that stem cell injections do their advertised job. And what that job is, if you're putting a stem cell into the knee, you want it to go from a stem cell into a cartilage cell, and you want it to regrow and replace new cartilage in the knee. While stem cells might be helpful with fighting inflammation and pain, just like a steroid injection or a gel shot or a PRP shot, those are a few different types of injections, it has not been shown to actually grow new cartilage in the knee. And that is pretty definitive and clear at this time. That may change soon because this is a problem that is being researched and developed at a very high level right now. But at this point, I am not a recommender of stem cell treatments. Are you doing shoulder replacement surgery at the surgery center. Right now, we are not, and that is due to some insurance reasons that will hopefully be changed in legislation and regulation over the next year. So at this point, we do not do total shoulder arthroplasty at the surgery center, but it won't be long before we are. Can you have a second knee replacement done on the same knee? You can. That's called a revision knee replacement. So that's when the first knee replacement has failed for one reason or another. And yes, you can. It's not an ideal situation. Sometimes it has to happen, but there are problems with that in the sense that the rate of complications, the risks that come with the procedure, the quality of outcomes all go down with the second surgery compared to the first. So while there are certainly plenty of revision knee procedures, as we stated before, a knee replacement can last for 20 years, sometimes less. And someone who has a knee replacement at 45 or 50 years old, they very well may need another knee at some point for a variety of reasons. So absolutely, you can have a revision surgery. You can have multiple revision surgeries if necessary. But the goal is to have a single knee replacement, have that be the metal and plastic that's in your knee for the rest of your life. Do you recommend total knee replacement if there is no arthritis except bone on bone? If you're bone on bone, you have arthritis. That is a high level of arthritis. It takes a while to truly get bone on bone. If it's a small area, a centimeter diameter area or a focal area that's bone on bone, that's a different story. There are treatment options for that if it's just isolated, whether it's cartilage replacement surgery or using cartilage to fill in that defect. But if you have degenerative arthritis that's bone on bone, and everything we have available to us in terms of conservative treatment has been tried, and you're still having pain, limitations, and quality of life issues, the recommended treatment would be either a total knee replacement or a partial knee replacement, depending on the factors we talked about previously. All right, any other questions? All right. Well, thank you guys very much for joining in and hanging out for a while. Remember, if you are experiencing pain, if you're having an issue with your knee or any joint in your body that, like I said, is not responding to the typical things you've tried, some of the simple things you can do at home, that is a good time to consider a visit to your orthopedic surgeon. So come visit us at OSMS. You can always request an appointment on our website, osmsgb.com, or give us a call. We have an acute injury clinic for walk-in patients for convenience sake and to save you a little bit on your time as well. So thank you guys again. I appreciate it. Have a good night.